Hi, everybody. Welcome to another session of Clinical Tips. I am Jin Kim. I am going to talk a little bit about a very particular situation, implant positioning, and how implant positioning can affect the longevity or the health of implant in many ways. When implants are placed in a poor position or bad position relative to many things, a disease called peri-implantitis can form. Peri-implantitis is a definition of exactly that, implant-related infections or infections around dental implants. I just Googled this a couple of days ago, and the Google shows the prevalence, how common they are, the prevalence of peri-implantitis today in 2025 to be somewhere between 5 to 51%. This is what the artificial intelligence has selected out from the vast world of the network out there. But let's look at some specific data that we have. In 2012, a group of scholars from the European arena reviewed a number of papers that was published in the dental literature. What they have found is upwards of 10% of all the implants in their studies, they reviewed 23 studies from various different aspects, different geographic regions and universities and whatnot. And more than 20% of all patients who had implants, somewhere between 5 to 10 years, ends up with peri-implantitis. This is a little bit alarming. Here's another study that was published out of New York City. This is from Columbia, where my son went to dental school. And from this data, what they have shown is something very similar. It's a dental school data, and what they had shown is about 21% of their implants and 34%, 1 in 3 out of all the implant patients after 5 to 10 years of implant use ends up with some form of implant-related infection and loss of dental alveolar bone. Let's look at a data that's a little bit more recent. This is another paper from European scholars, and this one is what we call the meta-analysis. This is a little bit more sophisticated analysis of the data so that it sort of equalizes many of the factors so that it's almost as if it's one study. This one, in the same time period, 5 to 10 years after implant was placed, shows that about 13% of implants and about 20% of patients have exactly that, peri-implantitis. Well, these are all academics, institutions, different parts of the world. Let's come straight home. This is my own practice. In my own practice, this young lady, Dr. O, when she was a student before she became a dentist, was helping me do a lot of interesting projects, and she came in and looked at the data from my own office, and this is a summary of it. Of all the implants, roughly 2,000 implants that I followed up in this particular study, about 1/3, 36%, had complications. Of that, the number one was peri-implantitis at 33.7%. 33.7%, that's a pretty high number. I was very generous and in categorizing what constitutes peri-implantitis. Even if I saw a relatively small amount of bone damage, I did classify it that way to be really good about looking into the data. The reason I prompted to do this video was this young man who I saw a couple of days ago. This gentleman came in, he's 32 years old, healthy individual, and he is missing a tooth on the lower left backside. The second molar is missing. It's been missing for about 3 years, according to his report. He said there was some sort of a cyst around the wisdom tooth and another molar. So 2 teeth were lost in this area. It looks like it has healed well. From this radiograph, I don't see any signs of issues. So it's a green light, let's go put the implant in. An implant will go in something like this, and ultimately a tooth goes in. Just a slam dunk, straightforward, easy day, keeps everybody happy. I did mention he's a 32 years old gentleman, and again, this is due diligence. due diligence. We have to do all the homework and look into all the aspects of diagnostics. So here I am reviewing what's called the CBCT, cone beam CT data, and we know that the yellow line, which represents the inferior alveolar nerve or the mandibular canal, is quite a distance away. So that gives us another layer of comfort. There is the impacted molar, the third molar, the so-called wisdom tooth on the opposite side, which is going to pose another issue. I wish this gentleman had that wisdom tooth taken up much earlier. But let's look at this area in a little bit more depth. This is his analysis of the CBCT data again, and I'm doing something fairly routine. You look at different sections, you try to look for anatomy, any features of what we call vital structures, nerves, blood vessels, tissue plane, the quality and quantity of the bone. And then we do this kind of a video game where we place a virtual implant to simulate the situation, what kind of angle works, what size implant works, all the kind of fun stuff to figure out that, our final goal. So based on that, this would be what our plan would look like. The nerve indicated by that yellow circular structure is a long distance away, so that means I can put in an implant of a good length, which is always a good thing, and the bone is not compromised in width or height, so I can put in an implant of a considerable width, assuring us that the strength and longevity could be guaranteed. So this is the cross-section of the site where the implant is proposed, and the red digital crown is a simulation of where the final tooth would be. So it's simply working backwards. That's where the tooth is going to be. That's where the nerve is. The nerve, by the way, this is how you want to understand it. That canal is called the mandibular canal, and inside that canal is what's known as inferior alveolar nerve, and the bundle contains blood vessels and other structures as well. So given that, that is a long distance away, slam dunk. However, on careful examination, we do see these yellow dotted areas where the bone is not quite healthy. Let's take a look at this again. This is a section slightly away, so we're doing our due diligence. And again, we see a couple of areas of bone that just doesn't look good. So again, his history was that he lost that tooth as a young man because of some form of cyst. Then it begs the question, did the previous clinician, was that person able to clean up all the remnants of pathology around the tooth? Was that area completely freed of any infectious or any unhealthy tissue? And that does beg a question. So at this point, we have two choices. Put the implant in after all this pathological tissue is removed, or try to avoid that. So here's a simulation of if I tilted the implant ever so slightly, we can still put in a good size, we can have it in a good trajectory direction, because otherwise if we put it in the most ideal position, we are going to hit that spot. You might ask, what's the big deal? What if the implant touches pathology of something that's been sitting there for a long time? We'll come back to that very pertinent question in a few minutes. So another option is to try to avoid the two spots that we can diagnose and recognize on the imaging, and perhaps put a shorter implant in an odd angle and try to get away. I think this is the actual way I'm going to be carrying out this case. The case is not done yet. I will be doing this very soon because the options are quite limited. And again, you ask, why don't you go and get rid of that tissue? The answer is yes, it can be done, but it's going to be quite invasive unnecessarily. So we're looking for the least invasive, the least problematic, but in the long run, we don't want to cause any problem because the patient happens to be a very young man. Just on another note, here is an impacted tooth that nobody seemed to have suggested. The gentleman said he just has it, there's no symptoms, but he is aware now that I've told him and showed him what the issues are that impacted wisdom tooth, what we call a horizontal impaction, because tooth is literally lying sideways. Let's look at this a little bit deeper. The highest point where the bone should be on that tooth, the second molar, not the impacted tooth, we really don't care about that one, but the tooth he is functioning on and the tooth we should be preserving, that blue arrow is where the bone should be. However, currently his bone is where the yellow sign is, and that's not a good thing. So the key question here is, how do we take the tooth out with minimal invasiveness without damaging any other structures, and try to bring that yellow arrow all the way up to the blue arrow and get all that lost bone back? Not an easy task. I have a couple of other videos on this, and then I gave a lecture back in 2020 on this very topic of how do we manage second molar defects, how do we grow bone in third molar sites. So look for that video. Going back to peri-implantitis, our original topic for the day. Peri-implantitis is, of course, one of the key reasons why we lose a lot of implants and have ailing and failing implants. So peri-implantitis, in this case, I am actually concerned that we might have this other form of peri-implantitis that is also known as apical peri-implantitis. Some people would like to call them implant periapical lesion, fairly synonymous to periapical lesion of a tooth, which is typically synonymous with root canal problems. So here's a case report, a fairly recent one, that shows an implant that was placed into an extraction socket that ended up with an infection at the apex, hence implant periapical lesion, IPL. Well, let me show and share a couple of my own cases with exactly the same problem, and hopefully we'll understand why this is such a pertinent and very tricky situation. The first case is a patient by the name of David. He was an older chap, and we had a 3-unit bridge that wasn't functioning well, so he chose to do an implant in that middle site, or what's called the pontic site. Upon looking at this carefully, there seemed to be some sort of a pathology, most likely a retained root in that area. We had 2 choices: get rid of it, clean that up, wait for it to heal, put the implant in, or try to avoid that somehow, which is what David and I chose to do. So I was very careful. The implant doesn't look perfectly straight, but there's a good reason for it. And this was done, and in 2011, the case was completed, and the crown was restored. The case was completed. Of course, the third molar, the problematic wisdom tooth, was removed. And we thought, that's not a bad job. We were all happy. The patient was happy. I was happy. And we went about our normal business. And lo and behold, 9 years later, what we are seeing is that a lesion started to appear. We started to see that on the radiograph, and soon the patient actually had symptoms. So this is the situation 9 years later. It's very clear what's happening there. The implant was still perfectly fine. It was very firm. It had enough bone support, but I was getting concerned because now this old lesion is starting to fast approach the existing implant and threatening it. Clinically speaking, there is a fistula. Fistula is where the infection just spits out into the surface, and there is a communication, a hole literally created behind that implant, which was otherwise a fairly well-functioning implant. So at this point, we did not have a choice. We had to go and get rid of the pathology before it will engulf the implant. So a surgical intervention was made, where I went in and dug out what was truly a retained root from a previous extraction many, many years ago. Now, that's all good. Implant was still healthy and functioning, but here's the problem. It left a huge defect behind, a bone defect, which I managed to clean up and sterilize with the Nd:YAG Periolase laser device. And we grafted the area, and eventually it healed. And in 2022, the original restoration worked just fine, and we were able to maintain the implant in its original glory and function. So that's a nice ending to that story. Well, the second case is equally disturbing and quite involved. So let's go take a look at my second case of similar type. This is Samantha, and Samantha had accident in the front area earlier on, so heroic dentistry was done, root canals were done in these two central incisor and a lateral incisor. I saw her in 2014 when the implants were placed in those two sites, and we thought everything went perfectly fine. This is the way the case was followed up in about 2017. The restorations were done fairly well. She was happy with the outcome. Teeth looked pretty, and she was happy and healthy with her new smile. And we are following up on the case. In the meantime, she, becomes a mother. She bore children, and life went on excellent and fine. Until in 2022, she started to have symptoms around one of those implants. And when we took the radiograph, I was surprised to see a lesion. This is very typical of what's called the apical peri-implantitis. Just like a root canal forms around a natural tooth, this is like a lesion, an isolated area of infection at the apical end of the implant. The unfortunate part is because implants are made out of very porous surface in order to have good bone contact. Once a lesion forms, it becomes a nidus for bacteria to breed. Once they start to grow around the implant threads, it becomes a very serious ongoing subclinical infection. We did not have a choice. This one also represented a fistula tract, and it was a low-grade ongoing infection, so I didn't have a choice but to go in surgically and actually cut that piece of the apical portion of the implant away. We basically did a implant cutting ceremony in order to clean all the infection away. And using the Periolase device, which is an Nd:YAG laser, I was then able to sterilize the area, especially the healthy implant adjacent, which was exposed, but I really needed to get all the surface completely sterilized so that we do not have this problem as an ongoing issue. So here is a side-by-side of the radiograph before and after this implant cutting procedure was carried out. And again, this is the earlier pre-operative radiograph. And following the final restoration, the crowns were not touched and they were preserved. And in 2024, I just saw this lady a couple months ago, and she's doing great. She's still smiling with the beautiful smile, and the infection is now gone. The problem is solved. So here's a side-by-side image of the implant that is cut and the other implant that is still intact. The infection is completely gone. There's no sign of it clinically or radiographically. And of course, we get a little bit nervous because now the implant is much shorter, and the question is that going to be strong enough? And of course, the patient being a young patient, we have to be very careful about long-term maintenance, making sure that the bite forces are very well, carefully controlled. The patient has to wear occlusal devices such as a night guard, and checking of the bite in a consistent way. So we briefly looked at the peri-implantitis and what effect it has. I am going to introduce this term called perigraftitis, which is now in the literature fairly commonly. As I mentioned, implant periapical lesion, apical peri-implantitis, is something we are quite commonly seeing. But this new term, perigraftitis, which was introduced by Dr. Jonathan Doe, he's a periodontist, a colleague of ours, and actually is a UCLA alum, actually introduced this to the literature not that long ago, and I would like to share one case very quickly. This is actually in the process of being published in a journal. We have just finished the histology. This was a disastrous case that ended up well, of a case where a previous grafted site got infected after I had placed an implant, which took a lot of investigation to figure out what was actually going on. This was a healthy implant that was doing great until a big chunk of bone literally fell out. And the histology was done recently with my pathology colleagues and the oral surgery colleagues at Daegu Catholic University, where I have the honor of holding a clinical professorship. So they have just finished this, we're analyzing, and we are writing up the draft to get this manuscript published, to let the rest of our colleagues know of this interesting and sometimes concerning cases. So I hope you enjoyed these cases and got you to think a little bit about more precise, more careful diagnosing for dental implants. Implant position does matter, and very small details could make or break an implant in the long term, including peri-implantitis as well as perigraftitis. I hope you have learned something today, and if you have any questions, comments, please comment below and subscribe to my channel, and we'll see you in another forum very soon. Take good care.